Good afternoon, good evening, or good morning from USC Visions and Voices, the Arts and Humanities Initiative. My name is Marie Renvelez. I use she, her pronouns. I'm a cisgendered woman, Asian American Filipino with tan skin, a round face, wavy ear-length black hair, wearing rounded brown glasses, a dark gray button-up shirt, and I'm standing in my small home office space in front of a white wall with some Visions and Voices artwork and multicolored string lights still up from the winter holidays. Welcome, and thank you for joining us for today's event, Behind Bars, Life and Death for Inmates in the Age of COVID-19, a lecture by Dr. Homer Venters. We have people tuning in from across the country and around the world today. And at Visions and Voices, we believe it's important to open our events by acknowledging the Indigenous land that we share. By presenting lectures and conversations like the one we have today, part of the work that we do is to make the invisible visible. The Visions and Voices program is based at the University of Southern California in Los Angeles, and we acknowledge that both the University Park campus and the Health Sciences campus were built on the ancestral and sacred land of the Tongva Nation. We honor the Tongva and all Indigenous people, past, present, and future, and we pay respect to their continued survival and their contributions to our society. We also honor the legacy of the African diaspora and recognize that this country would not exist without the free enslaved labor of Black people. We share these acknowledgements to raise awareness about the histories that are too often erased or forgotten, to pay respect to the original caretakers of this land, and to recognize our place in this history. We hope that this work continues beyond our events and helps to inform our individual and collective actions in the years ahead and for generations to come. Thank you. I would now like to hand this off to the amazing people who have worked very hard to bring this event with Homer Venters to you today. Please welcome USC Professor in Medicine and Law at the Keck School of Medicine and Gould School of Law, and co-director of the USC Pacific Center for Health Policy and Ethics, Alexander Capron.
Thank you, Marie, and welcome to everyone to the second of this year's Medical Humanities, Arts, and Ethics lecture, during which our speakers are looking at physicians' duties to their patients and to society through the lens of human rights. Today's talk is presented under the auspices of the university's Visions and Voices program, and I need to begin by thanking Marie Velez, Daria Yudakovsky, and the entire Vision and Voices team for their flexibility and creativity in helping us to deliver today's session online. I also want to thank the incomparable Keck audiovisual experts, Ruben Elias and Wolf McCarran, as well as my faculty co-organizers, Pam Schaff, Ron Benery, and Erica Wright from the Keck School's HEAL program, Humanities, Ethics, Economics, Art, and Law, and Sophia Gruskin, the director of USC's Institute on Inequalities in Global Health. Over the years, these events have featured lectures as well as music, theater, and literature to broaden and deepen our understanding of what it means to be a physician. This year, we're considering how an awareness of human rights as manifest in national and international laws and institutions may help physicians to better fulfill their traditional ethical duties to their patients, while also inspiring them to join with other advocates to make it possible for everyone in our society to attain the highest level of health and human flourishing possible. This past September, we heard from Dr. Colleen Kraft, a past president of the American Academy of Pediatrics, who became well known to the public for her advocacy for humane treatment of child refugees detained at the border. In March, Kate Gilmore, who has just completed 5 years as the UN Deputy High Commissioner for Human Rights, will show that these rights are not abstractions. They are means for focusing our efforts from personal to governmental on enabling everyone to be full participants in society, especially those who are most vulnerable to being dehumanized. This afternoon, our speaker will be talking about a group that is indeed dehumanized in our country, the more than 2 million Americans held in prisons and jails, the largest incarcerated population in the world. Dr. Homer Venters, a physician and epidemiologist, is a nationally recognized expert on health and human rights and the author of Life and Death in Rikers Island, which grew out of his 8 years as chief medical officer to the New York City jails. Following that, he was the director of programs for Physicians for Human Rights, where he pressed American officials to respond to war crimes such as the intentional bombing of hospitals and clinics in Syria, and then a senior health and justice fellow at community-oriented correctional health services, where he analyzed healthcare in ICE's detention system, provided injury and death documentation in prisons, and worked to reduce traumatic brain injuries. When the problems that are endemic to prison healthcare, the repeated violations of basic rights, the disregard for core values such as caring and respect, and a complete lack of transparency, combined with the coronavirus pandemic, the results are tragic. For the past 9 months, Dr. Venters, from his position as a clinical associate professor of medicine at NYU, has devoted himself to using the tragedy now engulfing prisons across the country to motivate physicians and public health leaders to join in efforts to seek the release of as many inmates as possible, since lowering density reduces the spread of COVID-19, and to advocate for greater accountability and long-term improvements in prison healthcare. So it's now my great privilege to invite Dr. Venters to present his talk, Behind Bars, Life and Death for Inmates in the Age of COVID-19. He'll speak for about 35 minutes, and then we will have time for some questions. You can submit questions at any time through the Q&A function at the bottom of your Zoom screen. Welcome, Dr. Venters, and thank you for being with us today.
Thank you, Professor Capron. Thank you to everyone involved at Keck, at USC, at Visions and Voices, and thanks to everybody who's tuning into this, hopefully, discussion remotely. It's a real pleasure to be with you all. I wanted to talk just a little bit about what I've been up to in jails and prisons in the last, during this time of COVID. I wanted to keep our human rights frame out in front as I talk about that. Talk a little bit about what's happening right now behind bars with COVID. Mention just a little bit about how I think we can leverage what's happening with COVID, as terrible as it is, for change, for the better. For people who have justice involvement to make lasting, meaningful change that has a human rights underpinning. And then to talk about really what are the first couple of steps that are required. And along the way, mention a little bit about why and how we got here into this terrible misadventure that we have in this country. So my name is Homer Venters. I'm a physician. I trained in social internal medicine at the Montefiore Medical Center, and went from there into a fellowship where I worked for a couple of years at healthcare provided to ICE, immigration detention detainees around the country. And needless to say, most of my analysis found that the healthcare they were provided was quite wanting, and that there was widespread both neglect and abuse of people in this system, that the system did not act in an accountable fashion or an evidence-based fashion. That work led me to start at Rikers Island as the deputy medical director, right out of fellowship at the time, and still New York City is one of the very few correctional health services, that's jail or prison health service, that's independent. That is to say, my boss's boss's boss at the time was the commissioner of health. And that's really important. That's a model that's common in Europe. It's almost non-existent in this country. If you look at our 5,000 jails and prisons, very few of the doctors and nurses ultimately work for a person who's running a health agency. They usually are working for law enforcement. And that's really important. So I worked my way up in that system with a real frame that was required from the beginning of human rights, because it was clear as soon as I started to see patients that our patients were exposed to really horrific brutality and bad medical care often and many other things, but lots and lots of new physical injuries, sexual abuse that was endemic where we worked. And so it was important as I became the leader of that health service to take on the principle of documenting the health risks and health harms that the system conferred to our patients. But it was also important to change the whole health system so we could do that and dedicate resources to it, integrate and change an electronic medical record so that we had standardized templates that would allow us to do those things. They would ask the question every time there was an injury, for instance, who hurt you? Was it intentional? But that really helped solidify for me my frame towards this work and the requirement of human rights. I then, have done a few other things, but I'll just mention, I guess up in, I was just asked today by somebody what I was doing a year ago. And a year ago, I was just moving into this role running a small nonprofit, thinking I was gonna, I was writing grants actually at the time, trying to think about how to like grow the impact of this nonprofit. But by February, it was clear that COVID was going to cause disasters behind bars, really lead to many, many preventable deaths, lots of illness, and that the correctional health services would not be prepared. And so in April, I handed off the reins of this nonprofit to some really talented folks. And since then, all I have done is go on the road and go to jails, prisons, and ICE detention settings and do analysis, independent inspection. Sometimes because a judge orders it, sometimes because there's a lawsuit, once in a while with the willingness of the people who run the facility, usually over their objections though, and spend time in those facilities, both seeing what's happening, but talking to people and learning the truth of their experience. And I think that this is really one of the core lessons from human rights that for me is also one of the core hypocrisies in how we approach health of people in the justice system is that all or many of the voices, the pathways for their voices have been shut off, and they haven't been shut off haphazardly. They've been shut off by deliberate, sophisticated, nuanced systems that lead them down pathways of grievances that are never responded to, sick call slips that are never answered, lead them into litigation that's hard for them to think about how to navigate, and they don't have the resources to pursue. And what it means is that when you go to these places, the most important thing you can do is talk to people there and learn from them what they've experienced. And so that's what I've been doing since April, I guess, in about 22 or 24 places. I don't know, I'm coming to you from North Carolina, where I'm spending the week in the prisons here doing that. And so COVID behind bars, I think everybody has heard, is, a very, situation's quite dire. I think that the take home I would want people to understand is that it's getting worse. We've had there's some data points out there that, for instance, we have had about 2,000 prison deaths documented. We don't actually know how many people have died in jails. And so, we have about 3,000 county jails in the country. We have about 2,000 state prisons, and then we have a few hundred places where people are in immigration detention. And I should mention a couple thousand juvenile detention centers. But we know that about 2,000 people have died from prisons, some amount of people in jails, I don't know. Some analysis shows that about 20% of people are known to have been infected in these places with COVID-19. That is a gross underestimate. I will tell you that one of the first places I went to inspect back in March or April was a Bureau of Prisons facility near where I live in New York. And, one of the first things I learned was that I went there because there was dispute over how serious the outbreak was. And the government was saying it's, mild, it's under control, it's essentially done. A few people had it. But when I talked to people in housing areas, there's some housing areas that were really made a huge impression on me. They were small. They were like shipping containers. Maybe if you put 1.5 shipping containers together, and then you put bunks for maybe 20 people, 25 people in there, and one little toilet. When COVID hit, they were locked into those areas. They couldn't come out. And so when COVID started, somebody got sick, and then quickly somebody else got sick, and then everybody got sick. And nurses might come by and hand out some Tylenol through the door, but nobody was getting tested. And that was happening in March. As the months went on, some facilities started to test more. So in Ohio, the big outbreak, and they tested everybody, and they found that most of the people in the facility had it, and they had quite a few deaths. As I've gone around, I usually am responding to outbreaks. Some of the facilities I've inspected, more than 2/3 or 3/4 of the people are known to have had COVID. But there are a lot of people that got sick before testing became common. There are a lot of people that got sick and simply didn't get access to medical care or didn't get tested. And so those numbers are really gross undercount. The thing I want to mention about COVID in correctional settings right now has to do with actually not so much what we hear a lot about, which is the close circumstances under which people live. I think we understand that, when you box people in very tight living conditions, the places in jails and prisons where people come together in close contact, obviously the virus is going to spread. But what I usually find is that, or I often find, is that pre-existing failures in the health services are actually the root of many preventable deaths. So this idea that there's something called sick call, which is when you're in a jail or prison or ICE detention, and you have a health problem, you can write it on a piece of paper, or you can write it in a kiosk, an electronic kiosk, and you'll be seen within a certain amount of time. That often just doesn't happen. And so people may have COVID symptoms, may have other problems. They may put in multiple sick call requests, and they may not ever be seen. And that contributes, obviously, to worsening morbidity and mortality when these outbreaks happen. Another really core weakness in correctional health services is the lack of adequate chronic care. So lots of people, probably half or more in most of the places I go, would fit the CDC criteria for being high risk for serious illness or death from COVID-19. And many of those people have either untreated or very poorly treated chronic health problems, which is a standalone or additional risk for a bad outcome. So I talk to people every time I go in a facility who have asthma, who use their albuterol inhaler every day or 2 or 3 times a day, because there's no chronic care program that's adequate to figure out the level of severity of their asthma and what they need to help improve their control. Similar problems for diabetes, for epilepsy, for other chronic health problems that are common. So these pre-existing health system failures drive a lot of the preventable morbidity and mortality, even though most of our focus is on the density, which is certainly very important. When I'm in these facilities, I ask the same 3 questions when I start. I ask the question, is the facility finding and responding to these individual cases the way they should? And the finding part has to do with adequate testing and screening. Responding has to do with not just finding people and putting them in medical isolation, but making sure that medical isolation is really different than solitary confinement, which it often is not. The second question I ask is, are they doing enough to slow the spread? And so that involves both the density of the facilities. A lot of jails, county jails around the country, have dramatically reduced their density. Many jails I go to now to do inspections might be at 50 or 40% of the capacity of people they had a year ago. Not true for prisons, and not always true for ICE detention. There are other things inside the facilities, obviously, that are important. Access to hand washing, access to paper towels, the ability to stay separated from people is very difficult, but it requires a commitment by the custodial or security staff. Those are things that have to do with the spread of the virus. and officers, how officers act and are trained around infection control, because this is not something that's inherent to security settings, the ideas around infection control. I would say that, in these detention settings, in these correctional settings, we do have some bright spots, and the brightest spot for just like in the community is that vaccines are on the way. Many states, I would say probably 2/3 of the states, have identified that people who are incarcerated or somewhere in this 1B, or, that they're gonna be eligible soon. I've only been in a couple facilities where they're starting to give vaccines, and actually the engagement of people, interest in getting the vaccine is higher than it was with H1N1, so I think that'll be helpful. But mortality is increasing. The deaths behind bars are going up dramatically this week, the week before, in the coming few weeks, and so this is a really dangerous time for people behind bars. And the number one tool is release, and it's release not just so that we can have fewer people behind bars and the virus doesn't spread, but it's so that we can get the high-risk people out. So that's the third question I ask, which is, what's the facility doing to find and protect high-risk people? And another number one thing you can do is get people out. And jails, prisons, ICE detention are all full of people that don't need to be there. I think we all, and I don't mean that just kind of in a philosophical manner. I mean, every state, almost every state, has enacted some sort of order to allow for people near the end of their sentences to leave. And very few states are using this as much as they can. So that, and then there are obviously places like jails and immigration detention settings that have much more broad latitude to dramatically reduce the number of people who are there. So starting with people who are high risk is really important. I will just say a couple of words about how I think that COVID and the problem of COVID-19 infection behind bars fits in with what I think are the larger human rights objectives for changing our approach to health care in these settings, and also promoting health of people that doesn't involve justice or law enforcement. Right now, we do have some fleeting involvement from the CDC and from DOH's, state departments of health. A lot of that has to do with interest in testing. The testing that's happening in jails and prisons usually involves some discussion between the prison or jail administrators and some state or national experts. The CDC actually put forward in March some guidelines around how to respond to these to COVID in detention settings. Those guidelines have been updated several times since March 23rd, I think. And those have been very helpful. I use those as tools. But what the CDC doesn't do, and what the DOHs of all these states don't do, is they don't go into these places and say, you're following these guidelines, or you're not following these guidelines. And so, as is the case with all the other healthcare behind bars, it's left to people behind bars who have their voices, pretty marginalized, to say nothing's happening here, or the right things aren't happening here. Litigation to be put forward by groups like the ACLU or the NAACP, who I'm down here with, the Southern Poverty Law Center, to advocate for people, and then for judges, to law enforcement, again, judges to come into the fray and say, okay, it looks like you're right, you're not doing these things, or you should do these things. But because we have this brief and focused involvement of the CDC and departments of health, I think this is a really critical moment for us in our country, because I think we do have the ability to take this involvement and figure out how to expand it. And I mean expand it in scope and expand it in time. It is critically important to get the CDC and the departments of health in states involved in not just putting out some guidelines or saying these are good principles, but to actually do what they do with healthcare in other parts of our country, which is figure out, is the healthcare that's happening adequate? And if it's not, what should happen? What should be done? What's the remedy? There are some other areas that I think really, as we think about not just COVID behind bars, but a couple areas I want to highlight. One is a metric we developed at Rikers, something called jail attributable deaths. So there is some review when somebody dies behind bars. Usually, if it's a jail or a prison, the level of that review involves somebody who has security experience thinking about whether or not a crime was committed when the person died. So even when horrible neglect is involved in a person's death, that may not be a crime in terms of the state's legal standpoint. If there is a health assessment, the health assessment usually is pretty perfunctory, and it involves trying to figure out were there any errors that are obvious in the care. But what doesn't happen is there is not an assessment of whether or not a lack of adequate care or a denial of care was part of the outcome of death. And that's really important because usually in these cases, a medical examiner will produce a report that says a person died of natural causes. But if the natural cause was, let's say, a person with diabetes who had diabetic ketoacidosis, it may be that nowhere along the line does anyone stop and document that the person was an insulin-dependent diabetic. This was known, or it was reported by the patient, and they died because they weren't given insulin behind bars. And that happens. Similarly, and that's the kind of thing that departments of health would be thinking about, and real, genuine health quality experts would be thinking about if and when a person died, for instance, in a hospital or in a nursing home. One of the areas that's really critical is the outcome of suicide. So suicide is the leading cause of death in American jails. This problem is directly driven by how jails respond to mental health crises. In most correctional settings, when a person has a mental health crisis, the next stop for them is a solitary confinement cell. Now, these cells often have a different label with them. They might be called a mental health watch cell or some sort of mental health observation cell. But the long and the short of it is when a person has a mental health crisis, they are going to be taken to a place where they're put behind a locked door and left there. And somebody might watch them through a vision panel, like an officer might watch them. A mental health person might come by and do a perfunctory couple of questions a couple times a day about, are you going to kill yourself? Are you still going to kill yourself? There'll be a lot of effort that goes into taking away the stuff that they could hurt themselves with, put them into an incredibly humiliating smock, which is essentially being naked with a big, very rough, it's almost like the smock that you use when you get an x-ray, the big lead-filled smock. But it's not a genuine health response. This is really the most common response, though, around the country. And we somehow have gotten to the point where for people who go to jail and prison, we've decided it's okay for them to get a response to mental health crisis that actually increases their risk of suicide, not decreases it. One of the things I do is I've recently worked with the U.S. Department of Justice on their civil rights investigations. And so just in the last few months, they issued a public findings letter with a state Department of Corrections, Massachusetts, where we had spent the last year and a half going to all of the prisons in that state. And they have finally, for the first time, the U.S. Department of Justice established that in their eyes, this practice of locking people in a cell after a mental health crisis, even if you call it a mental health watch, is a constitutional violation. And so that for me was really important for me to help with that case, because this idea of rights that have been stripped away, fighting to assign people or to legitimize the rights that have been taken away from people, I think is critically important in correctional health. I think that I want to just spend a couple more minutes talking about how we got here. So in our country, in these 5,000 jails and prisons, as I said, most of the health services report to law enforcement. What that means is that the people that decide what's the right scope of services Should we give MAT, medication-assisted treatment, to people with substance use disorder, or should we not? That's left to law enforcement people usually. Not just the scope of services, but the transparency. So who decides how much investigation or review there should be after a death? It's usually a law enforcement person. We have stripped away most of the evidence-based standards and certainly the transparency that we have come to expect in our own community health systems, and a dialysis center, and a clinic, and a nursing home, and a hospital. And we built a whole separate and hidden and incredibly substandard world, 5,000 little worlds, just trundling along and hidden by design. A lot of that really, some of that is attributable to the Social Security Act of 1965, I believe, or 4, which includes this inmate exception, which means that you can't fund healthcare for people who are institutionalized, which includes people who are incarcerated, with federal dollars. So it leaves the funding of all these places to localities, to states and cities and counties. That's part of the problem. But at the real core of this is really one of the most clear and ongoing and harmful representations of racism and health in our country. It really is almost the definition, or certainly a quintessential example of racism and health, to have decided that a whole group of people should get a lesser standard of care, a lesser standard of transparency, and almost no accountability for the health or lack of health access that they receive. And so, it's daunting, and I will say it's actually quite a sophisticated system, even though it's easy to point at the lack of healthcare or either abuse or neglect and kind of caricaturize these systems as being incompetent, but they're really often operating as designed, which is to keep people hidden and their health problems and health outcomes hidden from prying eyes. And so I think that the first step with all this, very daunting, sobering, and sometimes, kind of very depressing work ahead of us in this field, I think that we have some very good steps right in front of us now. I think that we have the CDC since March has put out multiple updates to these standards on COVID responses. And so my advice to everybody who will listen, the current administration and the new administration, is that we really need to make a genuine office of correctional health at the CDC. And that office shouldn't just put out more guidelines about COVID response. Those are good guidelines. It should do the same thing for vaccination in these settings. It should really come up with tools that are used by the CDC, to determine if these guidelines are being followed. And they should help state departments of health get into this incredibly important area, figuring out for COVID, starting with COVID, are these places doing what they should? So that it's not litigation, or it's not the hampered and hidden voices of the people who experience this that are the only ones that know. So that's the first step. Then I think we go on to involving this CDC Office of Correctional Health in other really important areas. The CDC spends millions of dollars every year to identify, educate, and prevent traumatic brain injury in youth sports, but they don't spend a single dollar to address the same clinical problem behind bars. And when we were at Rikers, we documented rates of TBI that eclipsed anything reported anywhere. We just reported the number of times people got hit in the head and the number of times they had LTBIs or concussions. Those rates dwarf everything in the community, but the CDC does not do anything about TBI behind bars. And it is a great example, again, of racism in health. And so this Office of Correctional Health that I'm opining about needs to take on identifying health problems behind bars. And they can't just be the health problems that we say people have who have justice involvement. You hear a lot of talk about, and it's true, people, because we push people with a substance use disorder and mental health, and people of color, and certainly people who have more than one of those things going on, into incarceration, Those are horrible, horrible misadventures in how we've used our justice system. But we also have to acknowledge that new health problems happen when people are incarcerated. They're exposed to physical abuse, sexual abuse. They're exposed to, they have injuries. They have bad health outcomes, including death, because they've been denied care or they get bad care. And the CDC needs to be involved in that, in monitoring and reporting and opining on these health outcomes that reflect the health risk of incarceration. We shouldn't have, for instance, shouldn't be to the Department of Justice and independent medical experts to be drilling down on why is it that locking people with a mental health crisis into a cell drives death. That should be the CDC, and it's a shame on them that they haven't been doing that. And so the CDC needs to really establish a legitimate footprint in this area that they have been AWOL in, but not just the CDC, the state departments of health that care about the adequacy of healthcare in nursing homes and hospitals. We have to force them to be involved in this area of care. We can't leave these critical tasks to law enforcement, even though, as I said, I've worked with the Department of Justice. You're in California, many of you. The Attorney General's office there, like in New York, has done really great work. Promoting a lot of important improvements for the health of people who are incarcerated. But we need health experts and health organizations. And if we want to even use the word health equity ever with a straight face, that means that if you care about health in a nursing home or a hospital, you should care about it behind bars. And there is really two final reasons that I think we need to get these community health structures involved in healthcare behind bars. So the first is, I think, pretty obvious to a lot of us, which is that we need to undo this problem of mass incarceration in our country. Almost everybody, I think, buys into that to some extent or another. But we don't yet understand actually how harmful incarceration is to health. And one of the big groups of institutions that have been left off the hook for this discussion about justice and reform are health structures, hospital health systems, departments of health, local and state departments of health. And by having them involved in understanding the true health consequences of incarceration, I think those are very specific voices, and health insurance, by the way, companies, that we need to bring into this discussion about undoing mass incarceration. But the final point I'll make about the need for these structures has to do with a problem that bears heavily on the people that work there today, and that's the problem of dual loyalty. We have, I would guess, a couple 100,000 people who work in health services in correctional settings around the country. I'm not sure I've seen a good number in the last few years, but those people work in very difficult circumstances, but they also work in structures that I mentioned earlier, generally involve security people being in charge of what they do. And this problem of dual loyalty is ubiquitous, but it's almost never talked about. When I talk about dual loyalty, when we talked about it in our own health service at New York City, it took us a while for it to settle in. And then after a while, when we started to train our staff on dual loyalty, they really warmed up to it. And they would tell us they want more training on dual loyalty and they want to talk about it more. Because as we started to examine together all the ways in which our role of caring for our patients are influenced by the security setting, it was overwhelming. And it wasn't just big, horrible things that are apparent to everybody, like being told to clear somebody for solitary confinement or not clear them, or maybe being pressured to say something write something on an injury report that wasn't true after somebody got beat up by a CO. But there are lots of little things that happen every single day. Getting pressure to not write an order for an albuterol inhaler because that comes with a front cuff order so that somebody can access it, and maybe they don't want people to be front cuffed, or writing an order for a cane in somebody that the security staff say is going to use it as a weapon. All sorts of examples popped up when we started to talk to our staff about it. And this is a problem that really is not talked about anywhere. But when I investigate deaths, certainly deaths that we identify as jail attributable, or something that happened behind bars was related to the outcome of death, what we often find is that health staff at some point stopped seeing the person in front of them as a patient. And they started seeing them in a way that the security service wanted them to see, as a threat, as a malinger, as a liar, as somebody who wasn't worthy wasn't worthy of healthcare. If you just put one clinical entity, I've seen 2 or 3 of them in the last couple of weeks, infective endocarditis, great example, where every time I look into a death that involves infective endocarditis, at some point a health person told the patient, well, you're an IV drug user, and so this is what happens to people like you. Putting aside, that's often not the case. It's often not the case that the clinical outcome has anything to do with that. But that is a great example of how the loyalty and a focus on the patient gets eroded in these settings. That problem of dual loyalty is never going to be addressed or fixed without community-based health structures understanding and helping to really draw a circle around it, identify it, and think about how we can look for it and mitigate it, the harm that it brings to our patients and to us as healthcare providers. So this frame of human rights really is critically important in promoting the health and the better health outcomes of people who are behind bars. And I, through the COVID work, certainly one of the reasons I do so much of this work is it's been very rewarding in some cases to be part of getting people released. When we can show a judge that a high-risk patient is better on the outside than the inside, or we can convince people who are administrators and policymakers. But even if this country goes from, as we did in New York City, we went from 20,000 people in the jail system under Giuliani to probably 40, over a little, maybe 4,000 today. So incredible reduction in the rate of incarceration. If the country did that, which I think would be a wild expectation, but if it did reduce incarceration that much, we still would have many people behind bars. And there is not a choice between worrying about or promoting humane conditions for people who are incarcerated and promoting the aim of abolition and the aim of undoing mass incarceration. They're together, they're connected. But only by drawing in our community-based structures of health, evidence-based structures of health, and this frame of human rights can we really establish some progress in this really important endeavor and start chipping away at what I think is one of the greatest edifices of racism and health in our nation. So I'll stop there. I really appreciate any questions, pushback, comments. Would love to hear people's ideas and questions. So thank you.
That was fantastic, Homer. Thank you so much. I have a favor to ask of you. If your cell phone is near the computer in any way, we're hearing the calls that are coming in on the line. So if it's anywhere nearby, that seems to be being picked up, the vibration. I'd like to begin with a question that we have had on the Q&A from a lot of people who are raising a request for help regarding friends and relatives who are currently incarcerated and either have medical conditions that put them at high risk or are due for release in the next year or so. What can you share with them at this time about where they could seek help to gain that early release that you were speaking of? Should people look to the legal system, to legal aid, otherwise to the government, or are there other organizations that they should be in touch with?
Yeah, this is a really important question. I'm sorry if I think I maybe have some street noise through the window of the hotel. I apologize. I think that starting with your legal aid organization, so in many places it's actually called legal aid, in other places it may be another provider, but the people who provide indigent or free legal services often also have a division or a group that's the Prisoners' Rights Project, certainly in jails. In most states, also the American Civil Liberties Union is involved. And between those two, you usually can get a good sense. I will say that state prisons have been horrible about this, and the Federal Bureau of Prisons has been very slow so we have so many people that meet the criteria that are slowly winding their way through the system. We've had much more impact with local county jails, and also even with ICE, we're at the lowest number of people in immigration detention in a long time. And through both some big class action suits and some individual habeas work, lawyers have been very effective there. But the state prisons, it's very difficult. And I know it's a horrible, horrible time for people and their families.
And the next question relates to whether at the state level or federally, there are any policies requiring any medical oversight from an independent body, that is to say, someone not under the corrections department or in the private companies that run these prisons. What is the status? Is there any model to look at of that kind of independent medical oversight other than what you or others?
I think that most of these settings, the security service is in charge of things, and so they decide what happens. I will say that the most important broad model, I just had a great meeting with these folks 2 days ago, is so in this country, we've ratified the Convention Against Torture. What we did not do is ratify something called OPCAT, the optional protocol in the Convention Against Torture. And while that sounds wonky, that optional protocol is actually the nuts and bolts of how you get independent monitoring and visitation of prisons and places of detention. And so all over Europe and most of the world where you have, where countries have ratified OPCAT, you have independent monitoring. I've done some of that work myself in other countries, but we don't have that. So now you have some states that do have some type of independent body. So like you might have a board of correction like we have in New York. You in California, I think, actually have a couple of different structures that might involve independent monitoring, but not oversight and accountability the way we have, for instance, in healthcare. When a hospital screws up over and over and over in their transplant service, you know what happens? They stop being able to do transplants. That kind of accountability is completely lacking. I think if you go Google Venters and then Lompoc, Lompoc, and then PDF, you'll find a report I wrote about the investigation I did at Lompoc, which is a Bureau of Prisons facility outbreak in California. And there, just go to the end of the report and read what I wrote about the deaths, where when I looked at the deaths, and then I looked at what kind of review happened after people died from COVID, and then I looked at the independent review that basically was somebody hired by the Bureau of Prisons, all of which said things were fine, there were no problems with care. I just find this to be incredibly wanting. So this is why we need the CDC and state departments of health, because you can't ask law enforcement for 1,000 reasons to be the deciders about if law enforcement does a good job with healthcare. It just makes no sense.
We just posted your Lompoc report on chat. So any of you who are watching who would like to download that can do so and read it later. One of our professors of public policy asked a question about protocols and asked, what protocols do you recommend for getting the maximum number of prisoners out of confinement?
Well, right now during COVID, most of the movement with judges, federal judges, has been around this issue of protecting high-risk people. And so I'm the medical expert in a case called Fraihat, F-R-A-I-H-A-T, which deals with immigration detention. But in that case, we've been able to establish, and a federal judge has forced ICE to do a review of every single person who is detained by ICE for to see whether or not they meet these criteria for being high risk. And so those high-risk folks are the ones that we've been most successful in advocating for release. Those general criteria are also being used by a lot of state prisons. And so I think the single greatest, from a health standpoint, the single most helpful thing is to figure out who's high risk. And I would just add that there are lots and lots of people who are incarcerated who are high risk, who are not documented as being high risk. So for instance, a person with really severe persistent asthma who never got a second controller daily inhaled steroid inhaler, but only was given an albuterol inhaler and is down as being having like mild intermittent asthma. That's a great example I come across all the time. Lots and lots of people who are incarcerated meet these high risk criteria, and they're not documented. And so for families and advocates, helping that process happen, doing sick calls, advocating for getting medical records and to show that people really are high risk is a very important task.
So when you speak then of medical records, you're referring to their civilian medical records, which could establish that they are a high-risk patient, I suppose.
That's exactly right. You know, because we have so many people, even though more people are in prison today, if we have 10 million incarcerations this year, which probably will have fewer, thank goodness, but if we had 10 million, probably 9 million would be in jail. So people are churning in and out of jails. Those are the kinds of places where they're not going to make the effort to get collateral information. Those are also places, by the way, that are designed to not have people see a doctor for a week or two. So the model for jail healthcare in this country is to have a very perfunctory interaction with a nurse on the way in, and then delay access to a mid-level provider or a physician until later. That structure exists solely to save money. But what it does is it actually hampers the ability to establish that people are high risk, which obviously, you know, the two are related. So these are different virtues that are being, you know, discussed on the same two sides of a coin. But what it means is for people going to ICE detention and county jails, it's really hard for them to establish quickly that they meet high risk criteria or that they are high risk. And so that's why for them, it's really a lot falls on their families and their legal team.
To the extent that resources are an issue, one of our participants asked whether you think the telehealth, increase in telehealth will be able to improve access to healthcare among incarcerated populations during and then after the pandemic.
I think that there are some areas where it already was pretty relied upon, where it's been helpful. Specialty care is, I think, a very important example where, you know, especially if there's a good chronic care service or even adequate or okay, they're identifying people that need access to specialists, either for assessment or treatment. And so that process was completely shut down with COVID. And in a lot of places, it hasn't started up. People aren't going from jail to go to oncology, cardiology, nephrology, unless the case is very severe, very dire. And so telehealth is an area where that process of access to specialty care can be greatly enhanced. I think that I worry about having core jail health services provided through telehealth because at the end of the day, people who are incarcerated need access to face-to-face encounters with doctors and nurses. But for specialty, I think it's a specialty, and some parts of the mental health service and substance use services can be provided, I think, in a way that helps.
We have a question which I suspect you encounter when you talk about the importance of decarceration, particularly in the time of COVID. And it's from one of our attendees who raised concern about not just the issue of would that increase violence in the streets, but also that even for prisoners who aren't violent, is there a risk, a health risk to the population, the general population, because of obviously very widespread COVID and other diseases like TB that are found among prisoners?
Well, I think that TB is actually pretty rare, even in correctional settings. I think in my whole time at Rikers, we have one case of pulmonary TB. I think it's different in other countries. I think that correctional settings are not opening up their doors in the middle of outbreaks and letting people stream out onto the streets. They're just, but I will say that, you know, this response of getting high-risk people out of detention settings is about saving lives. And it's saving the lives of those high-risk people, but also, you know, there are really scores and scores of correctional officers that have died in this outbreak. We have 500,000 correctional officers in this country, and we've had many deaths and a lot of morbidity among them. And so the COVID comes from the community into jails and prisons. It doesn't start there. It has never once started there. It comes from the community. It's a community pandemic. The people who come and go every single day in these places are the staff. The people who move around every day, the most of the staff, because people have been generally locked down. And so what we have is people who are just sitting there, you know, waiting for this to hit them. And to get people out who are high risk is incredibly important to saving lives. And most of the correctional administrators I talk to are really in favor of this because they're the ones that see what's happening to sick patients behind bars. They support this. It's, you know, in our country, it's the political will in state prison systems and governor's offices where we've really had a lack of action. And these, you know, we're talking about people in prisons usually who are at the tail end of their sentence, could be going home in a year or two, and who really under no rubric pose any public safety risk.
People would like to know what you think are the best strategies to organize, to advocate for shifting the control of prisoners' health to health departments rather than having it under law enforcement. How would you suggest that health professionals advocate for that?
Well, I think it depends where we all have access at different places. So for people who know or have contacts in the CDC and HHS, is that the CDC needs to get off its can and make a real Office of Correctional Health that doesn't just put out standards, but also starts working at whether or not these standards are followed and what are the other health problems. And so I think that for the folks that are in Atlanta that have connections there, that's, I think, where they can really have a lot of impact. I think that in state departments of health, you can see how advocacy around a couple of diseases has led states to get involved. So some states have involvement of the State Department of Health around HIV or adequacy of Hep C care. Like we have laws in New York about those two things. It's not about anything else about healthcare behind bars. In some states, they've already started. So in California, you have an AG's office that looks at immigration detention, and you have some other laws that have to do with jails now that are relatively new. And so I think that thinking about your personal access, if it's with a county department of health, a lot of counties have some STD involvement or some TB, as you mentioned, involvement, figuring out how to expand that little by little. These obviously, it took us, you know, decades to build this incredibly siloed system, and so it's not going to be fixed overnight, and it's not going to be fixed the same way. But I think that I just would advocate whatever your access is, whether it's at the national level with HHS or the CDC or local or state, to think about how you can push and advance this principle.
And from the inside, are incarcerated people being equipped with information of the sort that you've presented here, and so that they can involve themselves in the movement since it's about them?
No, I think that's, you know, I've been trying to figure out how to like categorize this, but so many times when I go to places, there have been or there are protests or security incidents happening because people are at their wits' end because they don't get any basic information. Nobody talks to them. The health service doesn't tell them what's going on with COVID. They don't update them. You know, one of the places I always insist on going is the disciplinary or punitive segregation, solitary confinement. And more often than not, I will find people who are in there for some COVID reason. That is, their house. I was recently in a place where they had a protest because laundry stopped, and people in a housing area that was under quarantine, the laundry just stopped. Nobody would do. They couldn't get access to new laundry, and they were sick, some of them, and so they had a protest where they wouldn't put their clothes on. And, they did other things. The really one of the most common problems is this lack of information and really incredibly widespread fear. And then that makes it hard for people to advocate for themselves. And so people will band together. They'll do things like write group letters. They may stage protests or hunger strikes. Those things will go to the ACLU or to local legal service providers, those letters. But it's really, their voices are so effectively shut out during these times that is really, for people, it's a very terrifying situation. I think that, groups like FAM Foundation or Just Leadership USA, I really think so highly of the people who lead and are part of those. Those are organizations led by people with lived experience. And so I try to lift up their work because they have access to, and, they're really with the families and with people who are incarcerated. And so I'll say it again, FAM Foundation and Just Leadership USA, helping and supporting them as physicians is really important because we learn more about the truth of what's happening, but we also can work together about ways we can organize, ways we can, like the Halt solitary bills around the country that have involved both medical and other advocacy together.
I'm going to have to call this to an end, but I want, as the final comment and question, to draw on a statement by someone who I think has probably been particularly inspired by what you said today. He says, "I'm a resident planning on working in correctional medicine. I'm currently working on a research project looking into the rates of health screenings at a county jail, and I'm facing a lot of resistance. I think the issue is because, as you have stated, there rarely is any accountability for healthcare provided at these institutions." And then his question is, how can we in general battle this resistance to accountability? Do you have any inspiring words for him or just keep on trucking?
I think that it thrills me to hear somebody just saying those words or thinking those thoughts. I think when I was a resident, I came across a case that made me so mad. It made me so mad, I can't see straight when I think about it now, about what a judge said about one of my patients, so bigoted and horrible. And it really lit this fire in me that I can't let it go. And so I think when you come across this, these feelings of like what happens to your patients and wanting to advocate for people, I think that there's so much work we have to do, but there's so much impact you can have. And so it's not just keep plugging away, it's think about who are the advocates and who are the people, not just in medicine, but in social work, people, banding together with local advocates, people with lived experience and their families can be so powerful. And so I'm thrilled. I certainly would love for the person who wrote that to reach out to me. Please feel free to share my email. I want to help and lift up anybody, follow anybody who's doing this kind of work, but kudos to that person and to anybody who's, thinking about how to take their real deep down atavistic, not just concern, but rage and need to tackle these problems and put it into motion. I'd certainly love to support or help anything you do.
Well, thanks again for this very informative and frankly, very disturbing depiction of prison healthcare in the current pandemic. I especially appreciate that you've offered suggestions for the ways in which the people who are attending this, the physicians to be, and other members of the public can become agents for change. Thanks also to all of you who have joined us this evening. I'm sorry we couldn't get to all your questions. We will pass them along, and you may hear from Dr. Venters. We are always striving to improve our events, so I hope you will all fill out the evaluation that you'll receive by email. And as an expression of gratitude to the students in the audience, we'll be holding a raffle with the winners receiving a copy of Dr. Venter's gripping book, Life and Death in Rikers Island. To be eligible for one of the 20 copies, please provide your name and contact information when you submit your evaluation. Thanks again, Dr. Venters. Goodbye to you all, and I wish you success in staying safe and sane in these difficult times. Good night.